اعطاني اياها وش اسمه حبيت اقول كتبتها بس ما لقيت.
I will tell you one difference between the intelligent students in Saudi Arabia and intelligent students in India and Pakistan.
Okay.
Intelligent students in Saudi Arabia, not only they are intelligent, they are clever also.
Oh.
You got it?
Yes.
They are clever also. But in India, intelligent students are intelligent. They are not clever.
I don't think so.
Huh? Really? I will tell you my example. I do not consider myself as intelligent, but in my class, we were a class of around 60, 70 people. So most of the people were considering me among the top. I remember in my whole life, we were 4 students, male students, 4 female students. In my whole life, I have not gone to the teacher for asking important questions. Believe me. And the syllabus doesn't used to come. The syllabus was not only from the books, it was the recent things which were coming in. Now recent, we have to search on the net. And look how much difficult it was to search on the net to get the books at that time. I have to visit from my Kashmir, I have to go to Delhi to get the latest journals. The big hospital, AIDS hospital is there. I have to go on my own expenses. Then search in the library which was full of dust. Okay, and get those journals out. And I was requesting that fellow, please give me the photostats. And sometimes I have to pay him also for getting the photostats of those journals. And even then, after doing so much of hard work, getting the good new things, sometimes the question is still out of there. So what you will do? So much difficult. You have to go to the recent advances of hematology, recent advances in cytology, recent advances in histopathology. There, the things are not simple. Like Dr. Abdul Rahman Main here, hematologist. No. Pathology, I have to do histopathology also, hematology also, cytology also, everything. The pathology is, he has to do all the things. If you see my CV, I have done all the things. I have done the histopathology, hematology also, cytology also. So if I go back again, I have to do all the things. So nobody is absolved. In the morning, I go for the FNSC. 2-3 hours I do the FNSC, come back, histopathology reporting. The next day, I have the bone marrow aspiration.
But this one is not
In
good.
between, yeah.
Not good for students.
For the pathologist, it is not good.
For students also, we need someone specialist in this. Like, for example, hemopathology, histopathology.
But you should thank Almighty Allah that you are having some pathologist. Isn't it?
Yes.
You are having someone. Because here, if you have a hematopathologist, so he will only teach you the heme immune system. What about the other pathology? So it's very difficult to get all the specialties, isn't it?
Yes.
For an MBBS student, it is very difficult. So if Dr. Abdul Rahman, he will teach only the hematology. The rest, what about the other blocks? Who will teach them? Isn't it? So it becomes difficult. So in a way, that is why in India, we don't divide the pathology. We keep it as such. So that is very beneficial regarding the staff also. It is good for the staff also. Later on, after the MD pathology, we have like DM hematology is coming up with their DM hematology or some specializations in the pathology. They are coming. This is about India. We are having in India, in Jammu, where I live in medical college, I am having 50 doctors in my department. 50 pathologists, 50. Can you imagine? Here?
And how about students? How many?
Students are also, students we have, in the pathology itself, we have 2 batches. 2 batches,
and
which are running side by side. Each batch contain about 100 to 150 students. 100 is
but
the minimum.
Still like not different. Like
Not only, this is only for the pathology.
Yeah.
But you can't compare India with Saudi Arabia. India is 1 billion and 100 million.
No, but I am talking
No, for
only
the
about
students.
my place.
Yeah.
Only my place.
Only.
Not about the whole India. Only my place, which is not a big city. Jammu city is
And
not
you
big.
said 50 doctors for 300 students, yeah?
Yeah. But we manage
There's
the
no big
hospital side
difference.
also.
نفس الشيء.
We manage the hospital side also.
But
Hospital.
50, big
50
number.
is big number. This is how you work. You need to have in pathology department or any department, you need to have minimum 2-3 professors. This is, the hierarchy. Professors followed by 3 or 4 associate, followed by 3-4 assistant, followed by the lecturers, followed by demonstrators. It's not easy. Followed by the PG students in that department, postgraduate students, followed by the MBBS students. They are in lab. Me as an assistant professor will not take even a single lab of the students. Who will take? The PG students will take. The people who are doing post-graduation in pathology. We are only supposed to take the lectures and do the reporting in the hospital.
You can't communicate with them.
No, they can come to us. The doors are open.
If you want to ask them, maybe you should ask, for example, the postgraduate students.
First, the postgraduate students. Then, if there are difficulties, they come to us. But we are mainly meant there to teach the postgraduate students, not the undergraduate students. Postgraduate students remain with us. Throughout the reporting, they will sit with us, they will write the reports, everything they will do. But then they will take the burden of teaching the labs to the undergraduate students. So this is, systematic everything. Here we are without hospital.
Yes.
There, for getting a medical college, you have to build a hospital first. You cannot get a medical college unless and until you have a hospital.
They are going to do now.
There, first build medical college,
Then
make
build the
doctors,
hospital.
then make the hospital. So totally reverse. So the second part is, the normal endometrial changes which are occurring. What are the types of proliferative epithelium? Here we will discuss about the endometrium. There we discussed about the smooth muscle tumors of the uterus. So endometrium, you have proliferative phase, secretory phase, and then the menstrual phase. So proliferative phase, you will find the glands will be tubular in shape, okay? Tubular glands with columnar cells, along with compact dense stroma. So these are the glands, tubular glands, and this is the stroma. It is dense. So as we move towards the secretory phase, what will happen? The glands will become increased in size, dilated and tortuous, okay? Along with the stroma, secretory, and they will secrete the things, secrete the material, and the stroma becomes loose. It becomes loose and edematous. This is how the proliferative phase goes into the secretory phase. So proliferative phase, tubular glands along with dense stroma, okay? Then early secretory phase, you will find some dilatation of the gland, and there will be vacuoles which appear below the nucleus. Vacuoles will appear subnuclear location, okay? And this is, post-ovulatory day 2. Late secretory phase, the glands become more tortuous and filled with the secretions. This is how the changes will occur. Then there will be shedding of the epithelium and menstrual phase will be there. This is the normal one. So please don't come to me after the class for asking the important things. Sometimes my mood is good, sometimes my mood is very bad, and sometimes it is like this. So it can be broken also. I will not broke it with my hand, but I will take that student and it will be broken, and there will be a big noise below, and then there will be problem. I will tell you in the class itself. Okay, what are the things you should omit? Like this slide. What do you have to do with this slide?
No,
this is
it's normal, not
so khalas.
Yes.
Clear?
Clear.
Second slide. Dysfunctional uterine bleeding important. Dysfunctional uterine bleeding. This is the abnormal bleeding in the absence of an organic lesion. Clear? You can have abnormal uterine bleeding. Abnormal uterine bleeding and dysfunction. Abnormal, you can have the organic lesion. It is a uterine leiomyoma, it is a cancer or something else. But here, abnormal bleeding is there, you investigate the patient. But you do not find any organic lesion. Okay? No tumor is there, no cancer is there. So, abnormal bleeding in the absence of an organic lesion. This is the dysfunctional uterine bleeding, which is DUB. Clear?
Yes.
DUB. Now, what are the causes? 3-4 causes are there. First and the most important is the failure of ovulation. Failure of ovulation, what it will lead to? When the ovulation fails, what will be the consequences?
Increase estrogen.
There will be increased estrogen, the progesterone will be very less because the proliferative phase will not be followed by the secretory phase.
Yeah.
Clear? So estrogen influences are more, progesterone is decreasing. But you need the progesterone for the secretory phase. Okay? For the secretory phase. So when the estrogen is more, what will happen? And ovulatory endometrium. The glands here, proliferative phase not followed by the normal secretory phase, and there are cystic changes. The normal secretory changes will not be there. Glands will become dilated in the form just like cyst. So cystic changes and the stroma will be sparse. There will be less stroma. Because this is required, the secretory phase for giving protection to the endometrium, or it's a support for the endometrium. So when the progesterone is not there, the support to the endometrium will be lost. Okay? So that is why there is shedding of the endometrium and there is irregular bleeding in the cycles. Because progesterone is not there. So support to the endometrium is not there. Progesterone is required for the support. So estrogen is more, no secretory phase, so less progesterone will lead to irregular shedding of the endometrium. This is one, failure of ovulation. Okay? This is the most common cause which occurs. Inadequate luteal phase. In it what happens? The corpus luteum fails to mature. The corpus luteum fails to mature, so what happens? Again, or it may regress prematurely. So what happens? Lack of progesterone again. Okay, again estrogen more, progesterone less. So support to the endometrium is lost. Okay, so there is shedding of the endometrium. Then older contraceptives, which contain high amounts of estrogen and progesterone, and irregular shedding. So mostly these are the two important things, but this in previous years it used to occur because of this. So failure of ovulation or inadequate luteal phase. So many females they come with these things. So you have to keep in mind, if you do not find organic cause, so you have to think of failure of ovulation or inadequate luteal phase. This can give rise to dysfunctional uterine bleeding.
Give me the second one.
Yeah, inadequate luteal phase. The corpus luteum, okay, it doesn't mature, fails to mature, or there is, it regresses prematurely. So there is lack of progesterone. Okay, so this progesterone is not there, estrogens are more. Okay, this basically I am discussing this just to give you an idea. Otherwise, this is a whole topic in the seminar. Abnormal uterine bleeding.
For the failure of ovulation, there is to the card, but that increases
Lack of the progesterone and increased estrogen. Yeah. Lack of the progesterone will lead to loss of support to the endometrium. There is a support. Progesterone is a support for the endometrium. When it is lost, there will be shedding of the premature shedding. Yeah. So this we will discuss inshallah tomorrow. Then the endometrites. Only one slide I have put just for your reference. You will discuss it in detail inshallah. I will ask you the questions.
Okay.
So endometritis means infection of the endometrium. Simple. Infection of the endometrium can be acute, can be chronic. So acute infections are mostly caused by gonorrhea and chlamydia trachomatis. These are the two most common organisms. And in acute you will find neutrophils. Khalas. Simple. Chronic you will find lymphoplasmacytic infiltrate. But plasma cells are required for the diagnosis. If you have to give the diagnosis as chronic endometritis, you have to see the plasma cells first. Without plasma cells, no chronic endometritis. Even if you find the lymphocytes, you cannot say this is chronic unless and until you find the plasma cell. Causes again chronic gonorrhea, tuberculosis, intrauterine devices, and retained products of conception. Okay? What is retained products of gestation? What is retained products of gestation? So maybe after there is conception, there is abortion. Okay, even after the labor, normal labor also, some of the products they are retained. They can lead to inflammation of the endometrium because this is abnormal. Abnormal things will cause inflammation, will cause infection. intrauterine contraceptive device. It can also lead, because continuously there is copper, released. Sometimes it can lead to inflammation in the, and many of the patients who are having IUCDs, they have inflammation of the uterus. There is continuous pain, there is dysuria, so they have infections. No, it is very common. Yeah, it is common. What I have seen in India, the patients, but I don't know about this because it has many other causes also. Females generally have some infections in the female genital tract. They have. It has something to do with the cleanliness also. Okay, something to do with the immune status. Females, in our countries, they feed the male members good, but don't take themselves good things. So immune system is already too low. And in some people who are out of Islam, they don't maintain cleanliness to that extent. Who use water. Without water you will not feel comfortable. You will feel no. They will not use. So just imagine. They will urinate, they will not use the water. And can you think, if even a single drop of water is on my clothes, I will not offer salah. I cannot.
Yeah.
So this is the difference. They will urinate? Class. Not even wash the hands. So I am very particular because we live in Hindu societies. I am very particular of already they don't know about the Muslim. So they are not pure in that respect also. So they don't have the concept of ghusl. So already they are ghusl. So that way also, and they urinate and hands are also. So it's very difficult. Alhamdulillah Muslims, but some of the Muslims are just like Hindus. This is India also.
Just in name.
Because the reason is they are living in Hindu societies. They are living in Hindu societies. They have adopted many things. One of the most important things which many Muslims in India have adopted from the Hindus are the Hindu temples. You know temples? Yeah. So they kept idols for worshipping idols there. And what the Muslims do? Some of the good fellows, they die. Grave is there. They build a temple on it. We call it Astan. I don't know what you call it in Arabic. But in Saudi Arabia, alhamdulillah, there is not a single one. This is, God Almighty will, forgive you everything. Everything He can forgive except shirk. This is, when your tawheed is good, you will be forgiven, inshallah. But if you did shirk, almost every now and then in Quran you will find these ayahs. So this you have to be very careful. There, this is the problem. But now people are getting, acquainted. Nowadays, I will tell you Kashmir. What do you think about Kashmir? Yeah, beautiful place. Muslim
Villages.
But I will tell you one thing. In even Kashmir, you will find in villages, you will find at least one to these asthans.
In Kashmir.
Yeah. Peer, you call it. Big sheikhs, they have died. Grave, with good, cover it with, multiple things and then build on it and people used to visit it. And some people offer salah also side by side. There are hadiths which tell us not to do this. Isn't it? You cannot offer salah there. You cannot build temples on the graves. This is complete shirk. Alhamdulillah, my concept is clear, Dr. Altaf's is clear. There are many people in Kashmir, maybe 30-40% whose is clear, but 50 to 60% not clear. And if you try to clear them, then
you will get problems.
Same like Makkah, when Prophet was there. What was happening there? Same, isn't it? So inshallah, we hope in future it will be gone. So this is acute and chronic inflammation. Okay? Acute neutrophils, chronic lymphoplasmacytic. And the symptoms will be many. Fever, abdominal pain, then menstrual abnormalities, infertility and ectopic pregnancy. Yeah, some of the products which are not removed. Suppose abortion is there, some of the products they are retained. They can cause inflammation. And you will find these are the glands. These are glands, and in between you will find lymphoplasmacytic infiltrate. And you should find these plasma cells. plasma cells having eccentric nucleus towards one side.
Doctor, is in the mesotype the difference in the cells.
Here neutrophils, acute, neutrophils should be present. Chronic, lymphocytes, macrophages, plasma cells. Here plasma cells are important.
Doctor, C trachomatis.
This is chlamydia trachomatis. Chlamydia trachomatis. No, endometritis is the inflammation. Another is the adenomyosis. What do you mean by adenomyosis?
Change the base. Adeno in the gland.
Meiosis means in the muscle.
Endometriosis.
Adeno means the glands.
Gland.
So we should say this is presence of the non-functioning endometrial tissue in the myometrium. Normally myometrium will contain muscle, but in addition it contains some endometrial tissue from the top. The endometrial glands and stroma, they come to lie within the muscle. So presence of non-functioning, but it is not functioning. Non-functioning endometrial tissue in the myometrium. What happens? It is due to downgrowth of the basal endometrium. So basal endometrium grows down and goes into the muscle. Okay? So downgrowth of the basal endometrium into the myometrium, and patients will have, when the something wrong with the uterus, dysmenorrhea, irregular uterine bleeding will be there. And uterus becomes thickened due to presence of these glands because these are in an abnormal location. Endometrial glands and stroma, when they are present in the muscle, this is abnormal location. So the myometrium, the muscle reacts, it hypertrophies. Okay? So there is hypertrophy of the muscle. And what you will find, look, this is a muscle tissue, okay? Myometrium. But you will find these glands within the myometrium. Within, they have gone deep, okay? So this will happen, trabeculation in the uterus, some redness is there, hemorrhage is there. So in general, the wall will be thickened due to presence of the endometrium because of hypertrophy of the muscle. Okay? So this is what will happen. Only one slide I have here, not more. What is the pathogenesis now? They say many things are there. Maybe due to trauma, maybe hereditary, some factors are there, maybe viral transmission can lead to this, or maybe hyperestrogenemia. But if you see what happens, if you see carefully, take multiple sections, you will find that these glands are in fact connected to the basal endometrium. You can find a connection. These are not totally separate. So this is basically the downgrowth. Sometimes in one section you will find only in the endometrium, myometrium, these glands. But if you see carefully, take multiple sections, you can find the connection between them. So it is basically not there only, but it has gone from above to down, downgrowth of the endometrium into the myometrium. So these are the causes. No need to remember these. Okay? No endometriosis. No endometrial tissue present in the myometrium is adenomyosis. But if it is present outside the uterus, it is endometriosis. Clear? This is the difference. Adenomyosis, endometrial tissue within the myometrium of the uterus. But if endometrial tissue is outside the uterus, it is endometriosis. Okay? And extrauterine localization of functioning endometrial tissue. That is non-functioning adenomyosis. Very good. And you should find three things. Then only you can say this. Glands, stroma, not only glands, endometrial glands, you should find the stroma also, and you should find the hemosiderin pigment also. So three things should be there when you will diagnose it as endometriosis. And it can be found in many organs. Ovaries, you can have endometriosis, pouch of Douglas, pelvic peritoneum, then rectovaginal septum, appendix, hernial sacs, umbilicus, lung or kidneys. So endometrial tissue can be found almost in a large number of locations. Yes. You don't know hemosiderin? What is hemosiderin?
Stain.
What is hemosiderin? Stain can be used to color. Yeah. So basically, it is derived from iron. Storage form of iron. You have iron, ferritin is one storage form, then is the hemosiderin. Okay?
Again, it means
Iron giving rise to ferritin. This is one storage form, which is in balance. Iron is reduced, ferritin gives the iron back. Or iron is more, it is stored in the form And ferritin can give rise to one more storage form, which is hemosiderin. Okay? So hemosiderin is basically derived from the iron. So these are the places where you can find this. This is uterus and you can find endometrial implants here. Clear? You can find here. You can find here in the ovaries. So you can find in the pelvic and abdominal cavity almost anywhere.
Vagina septum pouch.
Yeah, rectovaginal septum. No, rectovaginal septum. Between the rectum and the
Right,
vagina,
vagina.
there is a septum. There you can find. No, septum is not a pouch. Pouch is a cavity like thing. It is, septum is, fibrous tissue which separates two things. Huh?
We had it before.
If I say no, then you can omit it. So what are the theories of endometriosis? Theories are implantation. One, which is also known as regurgitation theory. Regurgitation theory means they say some of the endometrium from here goes into the fallopian tubes and goes back into abdominal cavity. This is the regurgitation. Huh? Regurgitation theory. Okay? So this can lead to endometriosis. Second is the coelomic metaplasia. As you know, there is coelomic epithelium which gives rise to all these epithelia in the genital tract and abdominal cavity. So this coelomic epithelium can undergo metaplasia. Can undergo this differentiation into various types of epithelium. So this is the coelomic metaplasia because it is basically the coelomic epithelium from which all the epithelia are derived. So they can differentiate along various pathways: tubal epithelium, uterine epithelium, endometrial epithelium, any epithelium, coelomic epithelium. So this is a metaplastic theory. Another theory. These two theories, regurgitation theory can explain the endometriosis in the abdominal cavity. Coelomic epithelium theory can explain it here. But what about the endometriosis in the kidneys and lungs? So
Blood.
here comes the lymphatic and hematogenous theory. Okay? So they say some lymphatics carry the endometrial tissue and take it to the lungs, or some blood vessel take it to the lungs or to the kidneys. So this is how. Huh? So three theories are there: regurgitation, okay, metaplastic or coelomic theory, and then the lymphatic or the hematogenous theory. It explains the presence of endometriosis in the different tissues of the body. So different theories are applicable at different times.
Doctor,
Yes.
coelomic metaplasia, where do they carry the endometrial tissue outside the normal side?
Yeah, in the abdominal cavity. Yes. Wherever you find coelomic epithelium, it can differentiate into the metaplastic epithelium or this epithelium, endometrial tissue. Is it clear?
Yeah.
Now what you will find ultimately? What is the appearance? Small nodules, red, blue, yellow, brown nodules or implants. They can be very small, only microscopic, or 1 to 2 centimeters, large also. On or under the surface of the affected serosal surface. Ovaries sometimes can be filled, they can contain large cysts which are filled with chocolate colored material.
Yeah.
We call it as chocolate cysts. So if you find this, don't try to open it and take it.
Blood containing cyst.
Yeah, this is basically long standing cyst in which the blood is there, that they convert, it gets changed in color and resembles the chocolate, okay? And this is, these are the implants, small implants, and this is the ovarian cyst. Big cyst, it has been cut and chocolate is flowing out from it. So these are the chocolate cysts. So chocolate cysts basically are endometriosis of the ovary. Clear? And this endometriosis can do the damage. What it can do? It can cause fibrosis of the pelvic structures. It can cause tubal ends to fuse because of the fibrosis, and it can cause the distortion of the ovaries and ovulum. Here the importance: when the fibrosis is there, it can cause infertility. Isn't it?
Yeah.
Fibrosis is there. If there is fibrosis of the fallopian tube, blocked, infertility. Huh? So here, tubal ends may be blocked because of the fibrosis. So 3 features for diagnosis you have to take: endometrial glands, stroma, and hemosiderin pigment. So what are the complications? First and the foremost is the infertility. this is one of the causes. When you are investigating a female for infertility, you have to keep it in mind, endometriosis. Then dysmenorrhea, painful micturition, pelvic pain, pelvic adhesion, dyspareunia, dysuria. Okay? The dyspareunia, dysuria I told you. Endometrial polyps. You know polyps? Polyps. 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 Simple. Actually, there is some light, so the pictures don't become clear, unfortunately. Polyps are outpoachings or growth from the epithelium. Okay? So they can be sessile, as I told you. I think on the female side. You have, somebody has some?
Yeah, there.
Okay. Polyps can be sessile, they can be pedunculated. Okay? They can be sessile or pedunculated. So, two types of polyps can be there. And endometrial polyps, they arise from the endometrial surface, go into the endometrial cavity. So, polyps usually occur in the postmenopausal woman. Okay? They may be sessile or pedunculated or may protrude. Sometimes they are big, coming from the endometrial cavity and going into the, protruding into the cervix also. So big are they. So I have myself, cut many uterus which contain endometrial polyp arising from the endometrium and going into the cervix. Yeah. So these are localized overgrowths, as I told you, asymptomatic or can cause bleeding. They can be asymptomatic if they are very small. Mostly they are present here, in this area, fundus of the uterus. Okay, single or multiple, mostly arising from the fundus, and they can have various varieties. Hyperplastic, which contain hyperplastic epithelium, atrophic, like this one. Cystically dilated glands are there. Okay, cystically dilated glands lined by inactive endometrial type epithelium, and you can have functional polyps, which have functional endometrium. So this was endometrial polyps. No, the important thing, endometrial carcinoma. Again, this carcinoma occurring at an older age, 55 to 65 years of age. And two things are very important here. It can occur in older women after the menopause. But if it occurs in the perimenopausal period, then what are the things in older women? Perimenopausal means immediately before the menopause. Okay. So in perimenopausal woman with estrogen excess, the variety is endometrioid carcinoma, which resembles the normal endometrium. Okay. Endometrioid. Okay. In older women, the endometrium has undergone atrophy. Older women. Okay. So in older women with endometrial atrophy, this is called the serous carcinoma. Serous carcinoma. So perimenopausal woman you will find endometrioid type. Older women you will find serous carcinoma. I will tell you the difference morphologically. And patient, how she will come. Marked leukorrhea, marked whitish discharge from the vagina, or there is irregular bleeding. So there is irregular bleeding, so the patient thinks there is something wrong. Or marked white discharge, too much. So it can be a risk factors. What is the risk factor? Most important, estrogen excess. Prolonged estrogen replacement therapies, endometrial hyperplasia, which is again due to estrogen excess. It can lead to estrogen excess causes endometrial hyperplasia followed by endometrial carcinoma. Estrogen secreting ovarian tumors, they can also cause obesity. It will also cause, because of increased synthesis of estrogen, diabetes, hypertension and infertility. These are also the risk factors. Okay? But this is well defined. The estrogen, this is well defined. Estrogen excess, because it has growth promoting effect on the uterus or on the endometrium.
The whitish material.
Leukorrhea.
Yeah, from where it's
It will come from the uterus.
Yeah, I know. What is content?
It contains, whenever there is a carcinoma, what will happen? There can be multiple infections also. So mostly the whitish material is because of the fungal infections, candida infection. Mostly the whitish discharge which is present in the females, it is the candida infection, fungal infection, mostly. Pathogenesis, how it occurs, two types we say, endometrioid and serous carcinoma. So endometrioid arises in the setting of endometrial hyperplasia. Okay? Setting is endometrial hyperplasia, and two types of genes are involved in this. Mismatch repair genes, DNA repair genes, and PTEN. Okay? These two genes are involved, and increased occurrence in some syndromes also, like hereditary non-polyposis colon cancer syndrome and Gordon syndrome. Serous carcinoma arises in a background of atrophy in older age. Okay, this is perimenopausal. This is older age in atrophy, and you don't find mutations in these genes. Here, DNA genes and PTEN gene are involved. Here you find P53 gene. So this is the difference between the two. What is the morphology? So morphology will be different for the two. Endometrioid type, you can have exophytic, growing out, and infiltrative, going inside the ball. So it is basically contains the endometrial glands, isn't it? Abnormal endometrial gland, atypical. So this is glandular. Glandular means having glands. But these glands can show differentiation like mucinous, tubal, and squamous differentiation, because coelomic epithelium can give rise to. Okay. So when the cells are atypical, they can also give rise to different types of cells and different types of epithelia. So mucinous, tubal, and squamous differentiation can be there. Grading again, 1 to 3, well, moderately and poorly differentiated. Staging is 1 to 4. When it is confined to the corpus of the uterus, stage 1. Stage 2, it involves the cervix. Stage 3, it goes beyond the uterus, but within the true pelvis. It remains within the true pelvis. And stage 4 goes beyond the true pelvis, or distant metastasis is there. So this is not so easy, staging. But I have made it easy. This is not that easy. Maybe there is further substaging, A, B, C also. So easy. 1, confined to the corpus. 2nd, to the cervix. 3rd, up to the true pelvis, and outside the true pelvis. Stage 4. Now the serous carcinoma, we do not grade it as such. This is poorly differentiated already. We call it as poorly differentiated, not graded, and aggressive, and highly anaplastic. Highly anaplastic. Greater cytological activity, atypia, and what you will find? You will find small tufts, small tufts of cells, and also the papillae, okay, containing highly anaplastic cells. This is what you will find in serous carcinoma. So two types are there, endometrioid and serous carcinomas. Now we will discuss the last one, gestational trophoblastic diseases. This is a very important thing, gestational trophoblastic diseases. It contains 3 things. H mole, we call it hydatidiform mole or H mole. Then is the invasive mole, then is the choriocarcinoma. These two are benign. You can say these are benign. H mole contains, one is incomplete mole, another is complete mole. Invasive mole, it is invasive only locally. But choriocarcinoma is a malignant variety. It can spread, go anywhere.
Doctor, all these are occurring during the pregnancy.
Yeah. Gestational trophoblastic disease. Only during pregnancy. So H mole can be complete, can be partial. What do you mean by complete and partial H moles? Complete H mole means there is no embryogenesis. So you do not find any fetal parts. Complete H mole. No embryogenesis, no fetal parts. But incomplete or partial H mole, there is some embryogenesis. So you can find the fetal parts. Okay? So here you find the fetus. Here, this one. This is part of the H mole, this is the fetus. So you can find some fetal parts in incomplete mole. Incomplete. Okay? So incomplete or partial mole is compatible with early embryo formation and contains the fetal parts. And has some normal villi. Because it is incomplete. But H mole, which is complete, doesn't have any fetal parts, no embryogenesis, and all the chorionic villi are abnormal. So this is a complete mole. Complete mole. You do not find any fetal parts. All the villi which you will find, they are abnormal. Okay? And one important thing here, it is diploid, 46XX. Mostly it is 46XX, sometimes 46X5, but this is diploid. Okay, but incomplete is triploid. 69. 69. You have one set of chromosome, two set, three set, triploid. So here you have diploid, here you have triploid, XXY. I will make it clear. So this is, you will find, when you see these are all grape-like stuff, just like grapes. So this is what you will find in H. This is a gross photo of a complete H-mole pregnancy with grossly identifiable, translucent, bulbous swellings of the terminal villi. These are grape-like. So the grape-like swellings you will find. What is the pathogenesis? This is very important. Pathogenesis is complete mole, empty egg is there. Empty egg. It doesn't contain any genetic material. Empty egg, which is fertilized by two spermatozoa. So in both, what happens? You will find here empty egg fertilized by two spermatozoa. So it is a diploid sperm, or a diploid sperm. So what it yields? It yields a diploid karyotype, two sets of chromosomes, because egg is empty, fertilized by two. Egg fertilized by two sperms. Okay, one contains one set of chromosome, another one. So diploid. Here in partial mode, normal egg, it contains one set of chromosome. So two sperms are coming, so three sets of chromosomes are there. Okay, this is how. This is diploid, complete, and this is diploid. Okay, so it contains only the paternal genes, isn't it? Only sperms. So here it contains also paternal as well as maternal. One set is from the mother, two sets are from the father. So this is how it proceeds. This is why how it is. Empty egg or here normal egg. So this is a karyotype. This is the difference. Very important. This slide. Karyotype 46 summarizes all the things. 46XX diploid. This is triploid mostly. You can have other varieties also, but this is the most common which I kept here, because then it becomes confusing. It should not be confusing. Villus edema. All the villi are edematous. Okay. All the villi are abnormal, but here some villi are normal. Okay. So trophoblastic proliferation, diffuse and circumferential, involving almost, diffusely involving the villi. Here focal and slight. So trophoblastic proliferation, I will show you the diagram. Atypia often here present. Atypical features are there in this, but here totally absent. Serum HCG, this is very important for diagnosing, H-moles. So it is elevated here, serum HCG. It is elevated. Here it is less elevated. In both elevated but less elevated here. If you go for the HCG in the tissue itself, so you will find much more elevation, 4 times. Here only 1 time. Behavior, rarely it can go, partial mole can rarely go into the choriocarcinoma, but here 2% of the cases of complete mole go into the choriocarcinoma, 2%. So more chances. Fetal parts here never contain the fetal parts, here it contains. So this, if you remember this is the karyotype, telling you about the number of the chromosomes, which we explained in the first slide, like this. This is the same. This contains the diploid chromosome number, this contains the triploid. So this is H-mole, bunch of grape appearance of the lesion, right? Like grapes. When you see it, when the specimen, you become very, we have seen with our eyes, grapes are coming. So again, these are not to be eaten. So this is the complete mole. It shows most of the villi. Villi are like this. These are the villi. In the pregnancy, these are the villi. Okay? These are normal, somewhat normal villi. So in the complete mole, all the villi are edematous. Cystically dilated, showing distended hydropic villi and proliferation. This is the proliferation of the cells, chorionic epithelium. But in the partial mole, some villi are distended like these, but some are normal. Okay, this is partial. This is not complete. Complete, all the villi involved. And trophoblastic infiltration. So there, whereas others are swollen, there is minimal trophoblastic proliferation here. So these are some villi which are swollen, others are normal, and maybe at some places there might be here, maybe some trophoblastic, not much. But here you will find trophoblastic proliferation. Trophoblast has proliferated. So this is the difference between the partial and the complete moles. Invasive mole. What do you mean by invasive? Invasive mole means it invades the myometrium. Okay, local invasion only. So these are complete moles, not the incomplete ones. Complete moles that are invasive locally, they do not have the aggressive metastatic. They cannot metastasize. Remember, they cannot go for metastasis. Only local invasion can be there. And they retain the hydropic villi which penetrate the wall deeply. So it only goes into the wall deeply. Microscopically, what you will find, more hyperplastic and more atypical changes will be there, because it has to be somewhat atypical to penetrate deeply into the uterus, with proliferation of cuboidal and syncytial components. Rupture, and sometimes, what are the complications? It can rupture because it is infiltrating deep into the wall. So it can rupture, sometimes causing life-threatening hemorrhage. Death can even occur because of this. It can locally spread to the broad ligament and vagina. Sometimes, only sometimes. Cannot be completely removed by curettage. If you do the curettage, some of it will remain. So you will find HCG elevated even after removing it. But this is not malignant, only locally invasive.
Can you repeat please, doctor?
Yeah?
Can you repeat?
What?
Last point. What you just mentioned.
Yeah. If you go for a curettage, you try to remove it by the curettage, it cannot be completely removed. Some part will remain. You cannot completely remove it, and because of that part, the serum HCG will be elevated. Because serum HCG will be secreted by these cells, so it will be elevated. So serum HCG is used to diagnose basically. Suppose somebody has abortion, okay? After the abortion, you suspect there is a mole. You do the beta HCG in the serum. Beta HCG elevated, there are chances of molar pregnancy, okay? So you say this is mole. Now, last slides, choriocarcinoma. So this is, from the chorionic epithelium you can have H mole, which can be partial, which can be complete, or invasive moles, which can penetrate into the uterine wall. Or you can have carcinoma also, arising from the chorionic epithelium. So arises from the gestational chorionic epithelium, common in the Asian and African countries. But it is not that 50% will follow complete H moles. As I say, 2% of the cases followed the, they have the complication of going into choriocarcinoma. So 50% of choriocarcinomas in complete H moles, 25% after abortion, and rest after even normal pregnancy. So a lady after normal pregnancy can have choriocarcinoma. 25% of the cases even after normal pregnancy. So there is no protection that a normal pregnancy is there and there will be no choriocarcinoma. No. Even after normal pregnancy, a patient can have choriocarcinoma. But the most important thing about the choriocarcinoma is that it is so fast growing, the tumor, like this, so fast growing that it overgrows its blood supply, and undergoes necrosis. So sometimes in the uterus you will not find the choriocarcinoma. You will find the metastasis in the lung, but there is no choriocarcinoma in the uterus. So fast growing that it overgrows the blood supply and undergoes necrosis and cleared by the inflammatory cells, and you will find no choriocarcinoma but there is metastasis in the lung. Okay? So grossly it is very hemorrhagic and necrotic mass within the uterus. Microscopically you will not find the chorionic villi. So no normal, no dilated chorionic villi like in the H mole. Okay? No villi are there. There is only cytotrophoblast and syncytiotropoblast. There are two types of
Trophoblast.
Yeah, trophoblasts are there.
Yeah.
One is the cytotrophoblast, which contains the cuboidal cells. Another is the syncytiotropoblast, which contains the cells lying in the syncytium. Multinucleated cells like. So it contains only anaplastic, cuboidal cytotrophoblast and syncytiotropoblast. Only these. No chorionic villi. Okay, this is the difference. And what you will find?
Fine.
Oh no, what will happen? Can it be corrected? So we will talk like this, one slide is more. So what will happen? There will be rising titers of beta HCG. The patient is coming to you with bloody brownish discharge from the vagina, from the uterus, and bloody brownish discharge from the uterus, and what will happen?
The diagnosis surgery.
And rising beta acidity titers are there. No, the thing is that this is one of the carcinomas which responds very well to chemotherapy. Which responds, no, I don't need it, I know. So which responds very well to the chemotherapy. Okay? And you can even 100% cure it by the chemotherapy. This is the important thing. Although this is very aggressive, it undergoes metastasis by hematogenous route, goes into the lungs. So lymphatic invasion is uncommon, but widespread invasion through the blood into the lungs is also there, 50% of the cases. But extremely aggressive, but responds to chemotherapy. Why the extremely aggressive tumors respond to chemotherapy? Aggressive tumors, well differentiated tumors do not respond much to chemotherapy. Aggressive tumors respond because of the rapid division. Because chemotherapeutic agents, they act on rapidly dividing cells where the DNA is dividing. So this is the reason. So extremely aggressive tumor going into the lungs, but responds very well to chemotherapy. Even you can achieve 100% cure. Okay. So here you can find neoplastic cytotrophoblast, cytotrophoblast, villi are not present. So it runs, diffuse cuboidal cells, multinucleated cells here. They run diffusely. Okay. And here you will find big cells. This is highly anaplastic. This proliferation of bizarre trophoblastic cells. These are all bizarre cells, having big nuclei, having more pleomorphism. Thank you so much. This completes the lecture.
Thank you, doctor.
If you have any questions, you can come.
Thank you.
Khalid,
كفاية
Bandar.